We'll start. Good morning. I'm Dr. Derek Au. I'm the director of the CHK Center for Bioethics. And this morning, we are very, very happy and honored to have two distinguished speakers to speak on the topic related to genomics for health, the social and ethical concerns and issues. We also have two excellent discussants from Sydney and also locally from Hong Kong University. Let me start by just introducing the two speakers. Our speakers this morning will be Professor Catherine Mills and Ms. Josephine JOHNSTON, and our discussants Professor Ainsley Wilson and Dr. Kelvin Ho from Hong Kong. I will introduce the first two speakers, and then they'll in turn speak the presentations. The sequence will then be for me to introduce the discussions, and then the open to the audience for Q&A and also commentaries. Our first speaker will be Catherine Mills. Catherine is a longtime friend of our center, director of the Monash Ethics Center at Monash University, where she previously held an ARC Future Fellowship. Her research addresses ethical issues that arise around innovative reproductive biomedicine technologies. In her current field of funded researches, she examines a wide range of topics, including preventing mitochondrial diseases, expanded non-invasive prenatal testing, and others. She has extensive record of academic publication, including 3 sole-authored books. And today her presentation topics will be your choice, reproductive autonomy in prenatal testing. And our second speaker is Josephine JOHNSTON, Director of Research and Research Scholar at the Hastings Center. This is a well-renowned independent bioethics research institute in Garrison, New York. She works on the ethics of emerging biotechnologies, particularly in human reproduction, also in psychiatry, genetics, and neuroscience. Her scholarly work has appeared in a wide range of disciplines of journals, and she also is doing research both from New Zealand and also collaborating with other parts of the world. Ms. JOHNSTON holds degrees in law and bioethics from the University of Otago in New Zealand, and she will be speaking on the topic of sequencing newborns, a case for nuanced use of genomic technologies. So now I would like to invite Catherine to come in. I'll stop my sharing the PowerPoint and let Catherine to come in with hers. Catherine, over to you.
Hi everyone, I hope you can see that slide there okay?
Yeah, we're seeing fine, thank you.
Great. So thanks, Derek, and thanks so much for inviting me to actually present today. It's quite an honour to be here with such illustrious company as Josie and Ainsley and Calvin. So thank you very much. And thank you everyone for coming along today. It's always really nice to be able to kind of engage with these topics with a wide audience. So hopefully we'll have some interesting discussion as we get through the papers. What I wanted to talk to you about today was a question that arises, which I think is a really crucial question about how we think about decision-making in relation to prenatal testing. So the framework that we currently work with is really, well, at least in Australia and I think in many other countries, is one of consumer choice. Prenatal testing is really
framed. I'm just trying to figure out how this works.
Sorry, what's happening?
So one of the audience has not muted the microphone, and yeah, I think she's done so. Sorry, Catherine.
That's okay. So what we place emphasis on in relation to prenatal testing is the idea of informed choice. And I really wanted to kind of tease apart this idea of choice. So a few years ago, a colleague and I did a project on obstetric ultrasound, which is when I became first interested in prenatal testing. So at that time, one of the things that really concerned people was how much non-invasive prenatal testing was going to transform prenatal testing in Australia. So this was back in 2013, so 7 years or so ago. So 7 years on, what we see is that non-invasive prenatal testing really has transformed prenatal testing in Australia. We've seen a quite rapid uptake of this test across Australia, quite considerable drop-off in numbers in terms of diagnostic tests like CVS and amniocentesis. But one thing hasn't changed. And that thing is the fact that we still think about prenatal testing in terms of choice. So we can still see from these two things, gotta remember not to hit my mouse. We can still see from this that choice is really the dominant framing. So in the top quote, this is simply about providing information that allows women to make their own choices. So this was an obstetrician commenting on obstetric ultrasound. And I've always really loved this quote because it really completely encapsulates the ideology of informed choice and consumer choice in relation to prenatal testing. So now, when we look at non-invasive prenatal testing, we still see it's your choice. Prenatal screening, tests in pregnancy, it's all about your choice. So I really want to kind of think a bit more about what that framing in terms of choice does and means. So just to give you a sense of the background position that I'm coming from, I'm really a strong believer in reproductive autonomy. So my talk is not about kind of reducing choice, but about how to create a context where women feel more supported, more enabled, and indeed more autonomous in making the choices and decisions that they have to make. So I'm not in favour of paternalism or any kind of restrictive legislation in relation to prenatal testing. That's not the angle that I'm coming to this from. So just to give you a sense of what I will be talking about over the next half hour. So prenatal testing requires women to make quite complex decisions about their reproductive options and well-being in situations of significant uncertainty, what can sometimes be situations of real emotional difficulty, and I will suggest something that we might understand as personal disorientation. So the question that I'm trying to ask then is how, in that circumstance, how are women best enabled to make these decisions in ways that promote or actually achieve reproductive autonomy? Is the framing of reproductive choice really doing the work of enabling reproductive autonomy? Is it really, I mean, it's kind of cast as equivalent to reproductive autonomy, but is it really, and is it actually even conducive to achieving reproductive autonomy? So these are the questions that I'm trying to address. And just to give you a sense of the structure of things, I'm going to talk very briefly about a bit of background on NIPT. I'll then talk very briefly about prenatal genome testing and disability, and then finally get onto choice and reproductive autonomy. So let me say a little more then about NIPT, which is really the main mechanism that we have for prenatal genomic screening at the moment. So NIPT was introduced clinically in Australia in 2012, and since then it's become increasingly popular. This is because it's convenient. It only requires a blood draw from a pregnant woman, and it's also highly accurate for trisomy conditions that are otherwise screened for in the kind of combined first trimester screen. So it generally takes place around 9 weeks. It gives a very, very accurate screening result for trisomy conditions like Down syndrome and the rarer conditions of trisomy 18 and 13. So when NIPT, it also gives results for fetal sex and increasingly for other kind of rare conditions. So when NIPT was first introduced in Australia, this is really what it was testing for. Just a very limited range of looking at it, 3 chromosomes within the genome. But now, one of the tests available in Australia at least is a kind of genome-wide analysis of all the chromosomes. So as you can imagine, it's going to be picking up a lot more than just the kind of standard trisomy conditions that that NIPT was first developed for. So it's certainly true that the increased accuracy of NIPT actually, and also the increasing range, has a lot of benefits. It can really provide very useful clinical information about potential conditions that a child has or a pregnancy that might affect a pregnancy, and in that allows women to make decisions about their reproductive lives and their lives as parents that they wouldn't have been able to make otherwise. At the same time, there's a lot of concern about ethical issues that arise around non-invasive prenatal testing, such as questions of consent and pre-test information provision, the ethics of selective termination, and how we think about disability, as well as significant concerns expressed by the disability community, especially in relation to Down syndrome, and as well as issues around post-test information and what information is actually provided to parents and what they can do about it, what the kind of decisional space is that they can actually kind of make decisions in. So it's this last set of issues that I really want to focus on, which is around the decision-making process in light of results that might be unexpected. But before I do that, I want to go through a quick detour through disability and some of the issues there, because it helps kind of set the background for what I want to talk about later. So as many of you might be aware, there's quite a lot of concern around the ways in which NIPT is feeding into different attitudes toward disability, and in particular in relation to Down syndrome. So internationally, there's been quite a lot of concern about the ways in which kind of national screening programs, for instance, have really led to almost, or what some people call the kind of disappearance of Down syndrome. So some countries are now seeing very, very low rates of children being born with Down syndrome. And for some people, that's something to be concerned about. So many of you might know this documentary, for instance, that was broadcast in the BBC a few years ago on a world without Down syndrome, and really looking at the ways in which kind of new prenatal testing technologies were influencing who was being born. These questions about disability become increasingly problematic, or for some people increasingly concerning, when we see the kind of increasing routinization of NIPT in particular, where it becomes a much more standard way of doing prenatal testing, and in fact becomes a kind of national routine screening program. So in light of this, we have to kind of think about what's actually going on here. So what I want to say is that as prenatal testing has become normal, it has also become normalized, meaning that what people do has actually come to be understood as what people ought to do. So these days, there's very few people who don't use prenatal testing in some form. And there are significant social pressures to do so, I think. There's interesting kind of empirical work on that, just that question actually. But I think it's also really important to note that, of course, not everyone uses prenatal testing and not everyone wants to. There are some people who are still seeking to have pregnancies without prenatal testing. What we know, though, is that genetic conditions that generate disabilities are very likely to be selected against if the opportunity to do so exists. So with prenatal testing, if there's unexpected results, then there may be an opportunity to terminate that pregnancy, and the evidence suggests that in many circumstances that's what women are doing. Again, not necessarily always, but likely. So there's lots of different studies in different countries and states of Australia, for instance, that show that not all, but most, sometimes most by a significant margin, pregnancies that receive an indication or a diagnosis of Down syndrome and other conditions are terminated. Sometimes, or at least people are worried that sometimes this happens before even receiving a definitive diagnosis. So it may be just on the basis of screening results, for instance. Now, I just want to add a caveat here about my image. I'm not suggesting that we're heading back to the old eugenics. We're not holding better baby shows, for instance, and we're not, hopefully at least, heading towards state-mandated terminations, though it has to be said that some bioethicists have made arguments along that line. Even so, I think we also have to recognise that this is not the only form that eugenics can take. And choice itself doesn't necessarily mean that we're not talking about eugenics. It may just be a new norm of a liberal or a flexible eugenics. So some feminist scholars have, for instance, written about this idea of a flexible eugenics that's really based on individual choice. And we have to ask this interesting question about, well, if it is all about individual choice, why is it that so many people are making the same choice, which is to terminate pregnancies when there's an indication of possible disability? So one thing we have to note there is that choices always take place in a social context, including social norms that favour some phenotypes over others. In a context of the expanded range of testing, and hence of the identification of conditions, the context of individual choice may make it likely that prenatal testing will actually lead to less phenotypic diversity. So we have to ask, well, what does this mean for people with disabilities? Would it mean that there'd be fewer resources for support services, for instance? Some people suggest that that might mean that there are fewer numbers of people with disabilities, mean that there will be more funding for those people. Personally, I think that's a naive view and misunderstands the nature of public funding. But there's also a question about, a slightly more philosophical question about this idea of the expressivist critique, which is a very strong, or an argument that's been made very strongly against prenatal testing technologies, which suggests that even using technologies like this actually sends a discriminatory message to existing people with disabling conditions. So it's really a way of saying, this kind of life shouldn't exist in the world. Your life is not worth living. So there's a lot of philosophical debate around whether that argument really holds or not. But I think it's a kind of interesting thing always to keep in mind as a background when we consider the ways in which social context actually shapes decision-making and the ways in which social norms really play out in terms of kind of determining the value of particular phenotypes within social contexts. I think there's also a kind of interesting question to ask in relation to the responsibility that such technologies generate. So it may be that, for instance, NIPT generates an obligation to prevent disability, which is what we might think of as harm. I'm not saying that's necessarily how we should think about it. But some people have also argued that, in fact, it also we might also have an obligation to preserve disability, that for the benefit of the world, there may be an obligation to preserve disability. But going beyond the kind of standard testing frame of NIPT, which is the trisomy conditions, I think we also have to kind of look at this expanded range and what that will do in relation to our ideas about disability. And here I think there's some really interesting edge cases in terms of how we think about NIPT and the ethics of that. So I just want to mention two, one of which is first cases of Turner syndrome or disorders of sex development, and the other of which is adult onset conditions. So one of the interesting things that's coming out of NIPT is that in screening sex chromosomes, we also pick up variations in sex chromosomes, such as in Turner syndrome for girls or Klinefelter syndrome with boys. Now, people with these conditions might not otherwise be diagnosed until their teens. They can live healthy lives of average length. They're thought to be infertile, but actually even that kind of understanding is changing these days. Because one of the kind of interesting things that happens with NIPT sometimes is what we can call discordant results and incidental findings. So sometimes with discordant results, it might look like the fetus has Turner syndrome, but actually it reveals that the mother herself has undiagnosed Turner syndrome. So there are circumstances when NIPT is actually telling you much more than what you anticipated, for instance. But it's also revealing that actually women with mosaic Turner syndrome may not be infertile in the way that we thought they were. So there's a question then about what we might kind of think about the ethics of that sort of testing and the decisions that are made around it. Another really interesting case is in relation to adult onset conditions. So one example of this is it's a really interesting case in the literature where a woman's decision to use NIPT for prenatal screening actually led her fetus and the woman's twin sister all being diagnosed with a predisposition to early onset Alzheimer's. So again, these are kind of very unexpected results. They're really kind of not what one is anticipating in going into prenatal testing. And I think it's fair to say that results like this can actually be profoundly disorienting. So what I mean by that is that they are major life events that can make it really difficult to go on the path that you think that you are on. So I mean disorientation fairly literally. If you are oriented according to a map that you have, a kind of sense of the pathway that you have, and then along comes this result that really pushes you off that pathway, that disorients you and forces you to come up with a new way of going forward. But I think more specifically, we can say that this involves a kind of element of moral disorientation, where the values that you thought were kind of embedded in your life are suddenly disrupted, and you have to then kind of think through your own moral values in order to find a new kind of path forward for yourself. So in the midst of all of this disorientation, we still say to women, it's your choice. And we do so in the belief that this is the best way to allow prospective parents to exercise reproductive autonomy. And I really want to ask, well, is that the best we can do? Is that really the best way to allow people to exercise reproductive autonomy? So, now my thing is not working. So to get onto that question, we need to think about what the choice model is actually doing in relation to prenatal decision-making around prenatal testing. So I want to suggest that the choice model actually positions embryos and fetuses as objects of choice. It makes clinicians the morally neutral service provider, their only role being to provide information, and it casts the gestator, which is usually a woman, not always, but usually a woman, as the primary, if not the only moral agent who's responsible for those choices. So the gestator, the women, are usually made responsible for the children that are born. And in that, there's also a question about whether they can be actually blamed for the children that come into existence. So there's a real, what we might call a responsibilization of women in relation to the decisions about who comes into the world. So then, if that's the framing that we currently have, how does this align with reproductive autonomy? I think we need to be very clear that choice in and of itself does not equal autonomy. It may be necessary for it, but it's not sufficient in itself. So if we think about what autonomy is, then autonomy is the capacity to make decisions and follow through on courses of action that align with one's deeply held values. That means being able, so what I will say about that is that autonomy is really about the authenticity of desires and emotions and the motives that you have to act. So it's your ability to kind of identify and act in accordance with your own values. So it's also about being able to act in accordance with those, which means that autonomy is an achievement. It's not just a kind of basic characteristic that people have, but it's actually a kind of achievement. So then how can reproductive autonomy be achieved in conditions of disorientation and epistemic uncertainty. And I'll just use that phrase, epistemic uncertainty, to point to the fact that becoming a parent is a really classic example of what might be called a transformative experience. You don't know what the experience of being a parent will be like for you before you actually do it. You can get all kinds of information. You can ask other people what that experience of being a parent is like, but you yourself don't know what it will be for you before you actually do it. It also is transformative insofar as it transforms who you are in the very process of having that experience. So it's a classic kind of transformative experience. And I think it's really fair to say also that becoming a parent of a child with a disability is also a transformative experience. So not just being a first-time parent, but say being a first-time parent of a child with a disability. So it's in that context of disorientation and epistemic uncertainty that we have to think about how autonomy is actually achieved. And I think it's important to say that being able here depends on various things. It depends on the choices that are made available. What options are even there and made available? How are they cast in terms of how they relate to each other? It might depend on very simple things in the choice architecture of how those options are actually provided to women. But it also depends on cognitive or internal parameters of decision-making, things like emotion, confirmation biases, the complexity of information that one has to work through in order to make a decision here. It also depends very centrally on social context. So one question we might ask here is, can someone afford to make an autonomous decision? That sometimes will make a difference to the actual outcome. So that goes to a question of kind of social welfare and how the decision to continue a pregnancy or terminate a pregnancy is actually supported economically within any given social circumstance. So I'm suggesting that our current kind of consumer choice model doesn't actually help achieve autonomy very well. It kind of leaves people in a position of disorientation and epistemic uncertainty and says, your choice. So the practitioners kind of step back. Or sometimes what it actually does is allow or not make it evident where people are actually doing something different from just stepping back and saying your choice. So that model, a different model, might actually be being practiced but obfuscated by the emphasis on choice. So what would be an alternative model? Well, some people have suggested that an alternative model of healthcare decision-making that may have relevance to genetics is actually that of shared decision-making. So this is a kind of model of healthcare that's become very popular in the last decade or so. And there's a few papers around how this might be valuable for genetic counselling. So shared decision-making, as you probably know, is based on this idea of shared information between both parties, that is the doctor, the counsellor, and the patient/client. There's supposed to be a kind of an agenda matching, and ultimately they're supposed to come to an agreed decision. So to sum up this idea, Elwin et al. Write, in SDM, the clinician, counsellor, and the client share information on the basis of which a decision is to be made. They then discuss their views and come to an agreed decision for which they share responsibility. Now that's nice. It sounds great in some ways, but I think there are some real problems with this model in relation to reproductive decision-making. For one thing, very generally, it completely obfuscates the relative authority of the counsellor, the obstetrician, and the woman who needs to make a decision. It really makes it very hard to see the ways in which different kind of relations of power are actually working in that context. Yeah. It's also very unclear what the relationship to autonomy actually is. And it ignores the very basic thing that the actual practice and moral consequences of decision-making are not shared equally. Women become parents, genetic counsellors don't become parents, or other ways around. They don't need to share the decision in this context. So what would be a different way of thinking about this? I suggest we need to actually start thinking in terms of something that might be called reproductive deliberation. So I'm going to suggest that reproductive deliberation actually combines elements of non-directed consumer choice and the shared decision-making models. So on my little pictogram here, you can see it's kind of sitting between shared decision-making and the consumer choice model. So here I think reproductive deliberation has to emphasise communication, similarly to the shared decision-making model, not one-way information provision, but actually a sharing of viewpoints through empathic dialogue and so on. It should also entail connection, which may be internal connection to the people involved in that dialogue, but it also might mean connecting women and couples to services external to that so they can get a different range of information, different kind of points of view to help them through that epistemic uncertainty that I alluded to before. It also should entail commitment, which might be commitment to values and also a commitment to recognise the nature of someone's values and encouraging courses of action that align with those, even if they're not a decision that you yourself would endorse. So the important thing to emphasise here is that this is an idea of deliberation as process. So I'm really kind of focusing on the process of decision making rather than the choice as an outcome. And I think it's in that kind of almost procedural aspect that we have to that we can support and enable the achievement of reproductive autonomy in this condition of disorientation and epistemic uncertainty. So to sum up, for a decision to be autonomous, it doesn't have to be made on one's own. Instead, it has to be a decision that the maker can actually own. My sense is that we need a framework for reproductive decision-making that allows women to say, I have the support that I need, but I still feel like this is my decision, one that I can live with and one that I can claim as my own. Thank you. And this is just the project that this paper is arising from, which is a current project that I have just recently started actually, and an undertaking in partnership with Illumina, Victorian Clinical Genetic Services and Murdoch Children's Research Institute. And I hope to have many more outcomes from in coming years.
Yeah, thank you so much. That's right on time, and that's an excellent definition of the issues and the concerns. I particularly thought that the look and at the definition or the conception of autonomy more than just the usual consumer choice. I think we'll pick up on that and in the discussion. Next, may I invite Josephine Johnston to present on her topic, and then we'll go into the discussion. Thank you, Josie.
Kia ora koutou, everybody. Yeah. I am really glad to be here. I'm here being a relative term these days, but I'm actually coming to you officially from two places. So I am a Director of Research and a Research Scholar at the Hastings Centre, which is in New York. But I'm actually on a long planned sabbatical in my home country of New Zealand. So I'm physically coming to you today from New Zealand, where I'm spending the year at the University of Otago in Dunedin. So greetings to you from both places, but especially from the Hastings Centre, which has a formal collaboration and exchange with Chinese University of Hong Kong. But that exchange has had to be on hold, of course, due to the pandemic. I was actually going to be in Hong Kong last year, but everything got put on hold. So hopefully at some point we'll be able to start that exchange up again, but really happy to be able to have this kind of scholarly exchange, even if we can't be together physically. So I'm going to talk today about a project that my colleagues and I did where we published our results 2.5 years ago. So it's not the most recent thing to come out of the Hastings Centre, but I think it's very relevant to today's theme. And it's also, I think, sort of interesting to think about in light of the fact that we have all been going through or are still going through a pandemic where the costs of public health, funding for public health, the importance of public health, but also sort of the costs of care are all kind of in it. Some seem a little different, I think, today than they maybe did in 2018 when the publication came out. My take-home message for today was kind of in the title of my talk, which is that sequencing technology has a place in newborn care, but it needs to be used discriminately or carefully. What we've tried here to capture with the term nuance. So I'm going to say a little bit more about what that means, but just sort of to preview where I'm going to be headed. I wanted to just say a little bit about the Hastings Center since that's where I'm from, but hopefully people are familiar. It's an independent research institute in New York. We work on a lot of different stuff. Here are just some of the projects that we have going on all different topics. Some of it's about healthcare, some of it's about technology and everything in between. And we publish a bunch of journals, reports, and a blog, and we do a bunch of public events. So just to sort of a little bit of an unusual beast, the Hastings Center, because it's not a university. It's probably one of the only independent bioethics and research institutes in the world. So just to give it a wee plug there. So as I said, this work today is coming out of a project that I did with colleagues at the Hastings Center and at University of California, San Francisco, specifically Barbara Koenig at the UCSF was the lead of this project. And Eric Parents and I and others worked with them. So I'll say a little bit about the project. But the background to that project is also important. So just sort of some context that shaped our work. We were doing this work in the United States. It was pretty US specific, although I think some of the ideas are applicable in other jurisdictions as well. Just about the US, there are 3.6 million births a year. And when we first started doing this work, there were closer to 4 million, but even with the drop in the birth rate, there's still a lot of babies born every year, 3.6 million. Seems like a lot coming from a small country like New Zealand where we...
Josie, your voice is not coming through. Have you?
Just muted me.
Yeah,
okay.
Yeah, you're muted accidentally.
Okay, sorry. I don't think I did that, but it told me the host muted me.
Okay.
You're very heavy-handed.
Yeah.
Anyway, here I am again. So US context, 3.6 million births a year. There's a system of newborn screening programs that screen for between 26 and 57 conditions, and I put in how many in New York, it's 55. That's essentially a mandatory screening program for all newborn babies using a combination of metabolic and other screens. So most children born in the United States will have newborn screening. Those programs are run out of the public health departments generally of New York states. So there are 50 individual states and each one has its own public health and newborn screening program. So it's not part of regular clinical care, but the results are communicated to the primary care physicians for those babies. So when you do follow-up appointments with your newborn, they will receive, your caregiver will receive your screening results for your child. Most US children, despite all the terrible things that happen in the United States in terms of access to care, most US children do have access to some kind of primary care. And there are about 500,000 NICU admissions a year, just to give you a sense of sort of the magnitude of NICU, that's neonatal intensive care unit or admissions. So that's just some background on sort of the situation. And then, of course, the other big piece of background driving this has been a huge investment in the United States for the last 30 or so years in genomics, beginning with, before this, but certainly beginning with the Human Genome Project that was begun in 1990. And as a result of that work, there's been a huge reduction in the cost of sequencing genome. So this is a nice graph that gets shown a lot that shows that the cost of sequencing a genome is now dropped to below $1,000 per genome. So this investment and this drop in cost sort of drives interest in applications of sequencing in a variety of different contexts, and newborns is just one of those. The person who's really had if any one person has had a lot of responsibility for really driving genomics research in the United States would have to be Francis Collins, who is currently the head of the National Institutes of Health, which is the biomedical research funder in the United States. It funds a huge amount of biomedical research that takes place. It's the federal government's funding program for research. And he is a big proponent of genomics. That's his thing. And he is very interested and enthusiastic about the use of sequencing in lots of different contexts, and is on the record as being enthusiastic about using it as part of newborn care. So here's a quote from his book from 2010. I'm almost certain that whole genome sequencing will become part of newborn screening in the next few years. It's likely that within a few decades, people will look back on our current circumstances with a sense of disbelief that we screened for so few conditions. So you can see a lot of enthusiasm there, and especially for it being part of the screening program that already exists as a sort of expansion of that program. Here's another quote from him from 2014. Over the course of the next few decades, the availability of cheap, efficient DNA sequencing technology will lead to a medical landscape in which each baby's genome is sequenced, and that information is used to shape a lifetime of personalized strategies for disease prevention, detection, and treatment. So not just enthusiastic about using this to detect conditions in newborns, but also about that then becoming part of the medical record that guides care for a person's lifetime. So all the way from cradle to grave, so to speak. It's not just people who are working in research who are putting a lot of effort and have a lot of enthusiasm for sequencing technology, but also there's a lot of commercial interest. So this is Anne Wojcicki, who is the CEO of 23andMe. So most people probably know that's a direct-to-consumer testing company, but also a company that's amassed a giant database of samples, and therefore sort of is actually kind of a significant player in research as well. And here she is talking about the use of genetic testing in children, and she says, I tested my son as soon as he was born, and I tested my daughter's amniotic fluid, so meaning when she was pregnant. Genetic testing is a responsibility if you're having children. So very relevant in a way, I think, to some of the things that Catherine was raising. Here's a proponent of genetics who has, leads a huge company that is arguing not just that, or not that genetics can help you understand who you are or connect you with lost relatives or might be fun, some of the sort of arguments for other kinds of direct-to-consumer testing, but it's actually the sort of thing that parents ought to do as in their role as parents, that it's the kind of thing that you have a responsibility to do for your children. So a much more powerful argument than you would see for something like ancestry testing, or there are various genomic tests to help match you with particular kind of wine or various different things. This is much more of a serious argument about parents having a responsibility to take care of their children's health through genetic testing. So it's also the case that there was, at least in 2015, a pretty strong suggestion that parents agreed with Wojcicki, that there was a lot of interest from parents. And this is a really influential publication coming out of a group at Boston Children's Hospital, showing that parents that they asked who had recently given birth or were the parent of a newborn were quite interested in being able to have genomic testing during that period, during what they call here the early postpartum period. So this study, among some others, was suggesting that there was a lot of interest in parents in additional or expanded testing of their newborns beyond what they would ordinarily get as part of state newborn screening programs and any sort of other checks that their pediatrician or the hospital might do. So in 2010, so that's now like over a decade ago, there was a workshop at the National Institutes of Health to look at the possibility of using DNA sequencing and analysis in newborn screening programs, and also as a clinical tool for newborns. And that led to a program of funding where projects would combine genomic sequencing with clinical research and looking at the ethical, legal, and social implications of that. And that in turn led then to 4 different big projects being funded. These were multi-million-dollar projects that lasted for 5 or 6 years, looking at aspects of the possibility of the use of genome sequencing in newborns, and each project had a different emphasis and a slightly different model that it was looking at. Some of it was looking at the use in the NICU, so with kids, babies where there's unclear but there's clear something's not right, but it's maybe unclear what, all the way up to the possible use in healthy newborns. And so we at the Hastings Center were part of the project that was run out of the University of California, San Francisco, specifically working with Barbara Koenig, and we drew on the research of the entire 4-project program and had people from those different programs involved in the study that we did. So we led this thing called an NSIGHT, that was the name of the projects, Ethics and Policy Advisory Group. We had a lot of members and we came together. It all seems so quaint and old fashioned now. We actually came together in person in a big library at the Hastings Center to debate and discuss and hear data about the possibility of using genome sequencing in newborns in a bunch of different contexts. And it was really an example of the ethics happening at the same time as the different studies were progressing. The guiding questions for this work were about the contextual forces that shape discussion of use of sequencing in newborns, under what circumstances they should be sequenced, how, and we specifically also wanted to ask about state-mandated newborn screening programs and how they might use sequencing, what role parents should play in determining how sequencing information about their infant is used and stored, and whether sequencing should be part of routine pediatric practice. And just a note to say that in the US, pediatrics is a primary care specialty. So every pediatrics and obstetrics gynecology are primary care. So if you are, most people for their under 18 would go to a pediatrician for their primary care, not a family doctor or a GP. Some do go to a family doctor or GP, but most people would be going to a pediatrician. So pediatrics is primary care, as is obstetrics. Okay, so the lead article here, the main part of this was published as a special report. We did a whole special report, which means a special issue really of the Hastings Center report, which is a peer-reviewed journal. Even though I work at the Hastings Center, it all goes through peer review, and I frankly think we're at least treated as held to as high standard as everyone else. I can put a link in the chat here to the full online. It's all available online. If you want to read any of this, you can look at the lead article, which is sort of the meaty part where we put our findings. And there are also essays by members of the advisory ethics and policy advisory board, where we kind of delve into various different sort of aspects of the topic that aren't really addressed in the main article. So there's a lot to read there if you're interested. So I'm just going to say a little bit about what we found. So we divided our work into we divided it into analysis and recommendations. And honestly, if you do conceptual work, normative work, some of the work that you do is just figuring out how to even talk about and analyze a problem. So I think the analysis is actually sort of at least as valuable as the recommendations themselves. So the first part, the analysis, we talked about 2 different reasons for using sequencing, diagnosis and screening, and just noted that those are really different purposes and goals. And so you can see that as it plays out in the different contexts we looked at, but like just to sort of now there is an overlap between diagnosis and screening, and it's a very interesting overlap that kind of creates a bunch of questions, but that there is in some sense really two quite different purposes at play. And they do get muddled sometimes in discussion. So we thought it was worth teasing them apart. Similarly, we actually divided sequencing into 2 kinds of sequencing. This is a little bit more of a tricky division, I think, but we needed to differentiate between what we call targeted use of sequencing and whole genome or whole exome sequencing. This is really to just point out that you can use this technology to go after particular questions or to sort of do a fishing expedition, if you like see what's out there, look across the whole genome, see what you find, versus look for in particular places for particular known things. And there ends up being a bit of a difference in how those run. One of the arguments we heard multiple times from scientists is that targeted sequencing is almost more expensive than, or just the same cost as whole genome at the level of data collection, but it really is more expensive at the level of analysis and interpretation to be looking at the whole data from the whole genome versus targeted. So that's another distinction we introduced. And then we looked at 3 contexts, and they are also different. So clinical context. Within clinical context, we were distinguishing between the treatment of sick newborns, so primarily in neonatal intensive care units. Those are hospital-based, very high-tech environments with a lot of specialists on hand to provide a lot of support to decision makers, whether that's parents and or the treating clinicians. And then that's really different from routine primary care. So that's community care happening in offices all around the country, very different contexts, both clinical driven and driven by the sort of norms and ethics of clinical practice, but really different environments in terms of resources and expertise. Public health, really different. So as I said, state newborn screening programs are part of public health. They use public health dollars, which are always in short supply. And of course, we've been all thinking more about that now since public health has been so top of mind with the pandemic. So that's a different context and answerable to different drivers and different ethics and actually even different law. And then direct to consumer being another really different, but also quite influential context, especially in the United States. And here are just a couple of companies that are in that zone of direct to consumer advertising that could be involved in the testing of newborns. I can say more about all of those. Then the ethical, legal, and social implications. Well, they're for whom? This is a huge topic, and there are a lot of different stakeholders in this space. And just to note that the impacts on these different stakeholders of this kind of technology would be really different in the different contexts. So it's a complex question to ask what the use of sequencing should be in newborns. And then finally, the structure of our ethical analysis, it really was, I think, in some sense, a little simplistically, but we needed to sort of simplify to some degree, a thinking about the just distribution of benefits. So how to so time to diagnosis would be a benefit, in certain contexts, you have a newborn where you're not sure what's going wrong or why the child isn't flourishing or why there's various kind of presenting problems, then time to diagnosis can be a really valuable benefit of sequencing if it can shorten the time to diagnosis, which it has been shown to be able to do in some cases. It can perhaps improve care, and there's a lot to say about that, but there are certain cases where sequencing is able to improve care, and there can be benefits to family members beyond the individual newborn of the use of sequencing. So in some cases, these benefits are available, and the just distribution of them should be an important sort of focus of ethics, but also protection from harms. So unnecessary follow-up and expense are harms that could come to individuals, but also to the system, the public health system or the healthcare system. Uncertainty and challenges to self-determination. So just really briefly, I'm sure everyone's sort of aware that there is an ongoing discussion around genetics about the right not to know. And we know from studies of adults that there are some genetic conditions that adults who are at risk for them because of family history choose either not to find out about or like to control the timing and circumstances of the genetic test that they take to actually determine that. And this will be things like Huntington's, but even treatable conditions like risk for breast cancer. We know that adults who are at risk want to have control over when and how they learn about their own test status for those genetic markers. So self-determination is an issue. And of course, when you're talking about newborns who really don't have self-determination, we have to think hard about whether there's any room for that in this kind of context. So that's another consideration we discussed. And again, all of these vary by context. So you won't be surprised to know that there are some special considerations that we focused on related to public health. State newborn screening programs in the US, and I think probably around the world, have a goal of offering testing and follow-up care to all who are eligible. So that's a really bold mandate in the US context where healthcare is not guaranteed. But that is what public health programs for states try to do. And so they take it very seriously, not just that every infant's tested, but that they then receive the follow-up testing and care for the conditions. Now, already there's an imperfect delivery on that last part about follow-up care, but that is one of the goals, and that's taken pretty seriously. This is a public health program with public health principles and public health trained individuals working in it. It's mandatory in the US because refusal is deemed not to be in the infant's best interest, given the nature of the conditions that the programs screen for. And so that's an important factor. And this is, of course, precious healthcare dollars, which I think is really relevant given what we're seeing with COVID. So a real concern not to stress these programs to the point where they can't afford to operate or where they are compromised. And the sort of realism about how much money is really going to be available. There's existing screening criteria for these programs derived from screening principles developed for all public health screening programs, and those include that a condition is screened for if there's evidence that there's benefit of early detection. So not just that you can screen for it, but that picking it up before there are symptoms or early there's evidence to show that that's more beneficial than waiting for symptoms to emerge, and that's not a no-brainer in terms of figuring that out. A condition will be on one of these newborn screening lists if states are actually able to screen for it, like they have the technology to do it and they can actually afford to do it, and if there are effective treatments available. So there are a few other criteria for being included in this newborn screening programs, but these are the basic ones, and they shape what gets on the list of what is and isn't screened for in this context. So the question for sequencing would be, well, can it expand that list by being able to enabling detection of other conditions for which there is evidence of the benefit of early intervention, and can that be, and for which there are effective treatments, and can that be done in a cost-effective way that states can manage? Okay, so our recommendations. This is getting to the sort of meat part of what we were doing here, and just to say that, like, we're pretty conservative in our recommendations here. So we were not, as a group, very gung-ho about the sort of use of sequencing left, right, and centre. In clinical contexts, we're endorsing the use of targeted or whole genome sequencing for diagnosis with parental permission, counselling, follow-up care, which is something that you can usually do in a NICU context because you have a lot of resources available. And we endorse the return of results that benefit the infant and or family members in that context. So where you, so that's kind of the best case scenario, I think, for the expansive use of sequencing was in the context of clinical context where you have a lot of resources and you can really follow up. But we did not think it was ready for use in screening, which meant it would be much less likely to be used in a primary care situation. So the reasons for that was that there is limited evidence of usefulness in asymptomatic infants. You have to test a giant number, use sequencing in a huge number of asymptomatic infants to find anything that wasn't picked up by other screening methods or by standard care. There's significant concerns and uncertainty about the storage of results. There's real concern in the US context about the subsequent use of sequencing results later as sort of against the child when they're older for insurance uses or in other contexts. There's some evidence that results can generate unnecessary distress, especially when there is no phenotypic presentation, and so therefore it's unclear whether the result is really that meaningful. And that there is some evidence that results can generate unneeded follow-up, and monitoring, which is then actually quite expensive and also onerous on the individuals and the family. And that, as I said before, there's good reason to think that children may wish for self-determination regarding certain kinds of results, which could be missing if we were doing whole genome sequencing in a clinical context for infants. So then it's not a surprise to hear that in the public health context, we were similarly conservative. We did not think that we should use targeted or whole genome sequencing as the sole screen. So we can't just stop doing what we've been doing and start sequencing all the babies because it cannot pick up some of the things that existing tools can pick up. So it could not replace all the existing screening tools. However, and again, you have these same concerns over the storage of results. I can tell you in the US context, the prospect of the government holding every baby's DNA is not something that that would be a controversial notion and would need to be addressed really carefully. And we're not ready for that. And again, similar concerns over discriminatory uses, distress, need for follow-up counselling. But it doesn't mean that you couldn't use targeted sequencing in those programs. So it could be that it already actually is being used as a secondary test following a positive screen for certain conditions. So to target in and really confirm. But it could also be a primary screen targeted sequencing to detect conditions that meet all the existing screening criteria, but aren't yet able to be screened for because the technology didn't exist. So this is a way we could expand newborn screening programs, provided that we're looking for conditions that meet the existing screening criteria. And there really is an open question there about cost, unfortunately. So for direct to consumer, we were not so very high on this. Parents, we thought, should not use direct to consumer sequencing for diagnosis or screening, and healthcare professionals should recommend against it if it's brought to, if a parent says, do you think I should go and get this additional test done through this company? We were cautioning them to recommend against it for all the same reasons about the unnecessary distress, follow-up care and monitoring that would be generated if lots of people went out and did this on their own dime, but then came into the healthcare system with the results, and then further testing would be, of course, inside the healthcare system. And so here's my little sort of ad I generated for my company, LifeSeek, where you would get your child sequenced and everybody would pay a monthly fee to get little results throughout their life about their kid. And it seems like that's all not going to work based on our recommendations. So LifeSeek is no longer operating, I'm afraid. Just a wee joke there. It was good to see that the results of our work were picked up by an editorial in the Lancet that pretty much endorsed our sort of caution. We also were happy to know that a group at the CDC read it. We gave a presentation on it to the Secretary's Advisory Committee in the US, which is the group that's responsible for advising states on what they should add to it, whether they should expand their screening and in what ways. And so they also engage with it in a positive way. And so I need here to sort of acknowledge the how this was funded, this work, and again to point you in the direction of the whole report if you want to read in more detail. So yeah, thank you. I look forward to your questions and to hearing how this might shake out in the different healthcare systems that you're working. Thank you.
Thank you, Josephine. That's a really comprehensive overview of the issues and concerns. And I'm really glad to see that what was discussed at the Hastings and in the research project is now picked up also by people in the other fields and also the policy level. May I now next invite our first discussant, Professor Ainsley Nielsen, to give her response. Ainsley, to you.
Hi, everybody. Thank you so much for having me. It's wonderful to be here and to see you all. They were just two phenomenal presentations. Thank you so much, Catherine and Josie. And I'm not at all intimidated at trying to draw together some discussion points. I'll just start by just noting that I'm involved in a range of projects and have published across both of the topics that were discussed today. And I'm also currently thinking a lot about how public health and clinical ethics meet and indeed sometimes converge in this area, and how the ethical considerations in those should be teased out when it comes to the use of genomics at scale in human reproduction. And I think my own epistemic experience as well, just to contextualize, is that I'm a parent to two children. And as Catherine alluded to, it was indeed a transformative experience to go from being a theoretical parent to an actual one, and it continues to be transformative as I go through that. And something that was really interesting for me was experiencing uncertainty during prenatal testing, and that really nuanced a lot of the views I held about these things. So just onto your presentation, Catherine, I completely agree with what you said. I think there is a huge problem with the current rhetoric around choice, and also I think pinned to that, the sort of linking between choice and autonomy, as you say. And I think it's a very thin conception around autonomy and how information feeds into that, and information provision being sort of seen as the panacea. And I really appreciated your unpicking of that and some of the concerns you raised, such as responsibilization. And I think, I really liked your terminology of moral disorientation, and I would actually even take it further to say moral disruption. I think these are disruptive technologies, and they are totally changing the experience of antenatal testing. And so I think moral disruption is something that we could think about there too. You alluded a little bit to how non-invasive prenatal testing is happening in Australia, and here at the University of Sydney, there's a team that's done a bit of empirical research about that, and we've got some publications in preparation at the moment. And I think something that's really come out of that research is the laissez-faire way that NIPT has been rolled out in Australia, not least the fact that at the moment it's really being commercially led and commercially implemented. And it's also being offered to pregnant people by non-specialists. So it's being offered sometimes by people that don't have appropriate training to engage with women around reproductive deliberation. And so I think there's a lot there that really needs to change, both how we approach things theoretically, but also practically. I was just going to point out one thing to do with the term informed choice. I think part of the problem is that this term means different things, maybe depending on which disciplinary background you're coming from. So informed choice has quite a distinct meaning in health psychology. And I think sometimes in clinical practice, the way that we talk about it in bioethics and the way that it is meant in health psychology, for example, tend to smush together, and that leads to a bit of conceptual disclarity. And I think an important thing to do might be to try and tease those things out. I also really liked your comment, Catherine, about you said if it's about individual choice, then why are so many choosing to terminate? And how you propose reproductive deliberation as one way to sort of push back against the current status quo. And it got me to thinking about I think there's a lot of women at the moment, or a lot of people making these kinds of choices at the moment who maybe strongly believe or strongly feel that their choice is autonomous, but actually it might be shaped by some of the more hidden aspects, such as social construction of disability, the way that the health professionals smiled at them when they were describing the test, etc. And so how do we engage with women who think they're making an autonomous decision but actually might not be? And of course, we want people making these decisions to feel supported and enabled. But what do we do about these kind of hidden constraints that are maybe harder to discern and might fall outside the professional-patient relationship? They might be more structural, for example. So that was just a question to leave you with. Josie, I'll just quickly turn to your presentation now. Just the Australian context here is that there is some interest in genomic sequencing in newborn screening in Australia, not quite the enthusiasm of the United States yet, but it is noted in policy documents here. And I think we'll start to see more and more activity on this in the coming years. We've also had a really successful pilot project on the use of genomic sequencing in the NICU environment here that's led to quite a lot of publications. And I was at a meeting a couple of years ago where this topic came up, and one of the very senior genetic scientists in Australia said, the only problem with using genomics in newborn screening in Australia is the ethicists tell us we can't. And I'm like, well, challenge accepted, actually, because like you, I share a lot of the concerns that you've summarised in your Hastings Centre special report. And I think, ultimately, we're not ready for this technology yet, or at least if we're going to use it, it needs to be done so in a very prudent way. And so I share a lot of your concerns about technology-led implementation, not defining whether the need is a public health or clinical need, or indeed even how those two things interact with each other in a conceptual and practical way, or the harms that could arise from this. And also, I think last but not least, the ethnic disparity that we currently have in a lot of the interpretation databases that we're using. I think there's a huge problem in that. My phone is telling me that I'm already out of time. So I'll just say a couple more things before I hand over to Calvin. I think another concern here is around health literacy, and your LifeSeek idea around, I think an issue that maybe has come up since you published your report is the emerging debate about reinterpretation and recontact and how those responsibilities might come out. So I think a sort of question I had for you is around this idea of family benefit from newborn screening. And I know that's been part of the debate in the United States. So if we have time to get back to that in the response, I'd be really interested to hear a little bit more about that from you, just in the sense of it's often used as a justification, and just how that tension perhaps between the health interests of the individual newborn compared to maybe the role that this information might play in the broader family. And just because a newborn is a sort of captive individual that is readily able to have that sample taken, just how seriously we should take that justification. But yeah, thank you to both of you. Just really excellent, extremely rich presentations, and I really enjoyed listening to them.
Thank you, Ainsley. That's really sharp comments, and we'll come back, let the presenters to respond to your question in a minute. But first, let me invite Calvin to put in his comments. Calvin?
Okay, thank you so much, Dr. Au, for the invitation, and also Ms. Joey So for organizing this event. It's always wonderful and instructive to hear from Catherine, Josie, and of course Ainsley, whose work both my students and I study. So extremely humbling experience as well. So thank you so much. So I think it's really interesting to think about the presentation starting from perhaps a more relational kind of context and then moving towards something that's more systemic. So Josie's excellent Hastings Center report speaks to a number of the systemic issues that we are beginning to see. So, but I thought I'd want to also bring in at the end of my comment the technology question. So, so how do we deal with these sorts of technologies? Of course, NIPT is just one of it, and we will see a lot more of these sort of developments in the coming years. So starting with Catherine's very insightful presentation, I fully agree that there are serious problems with a consumer choice kind of approach, and I think this links up very well with what Josie has mentioned about the direct-to-consumer kind of testing, a whole host of these sort of tests that we find today. The transactional kind of framing of the physician-patient relationship, I think it's something that is extremely problematic, not just something that we find in places like Hong Kong or Singapore, but also further afield. So here, I think that people, as Catherine, you have alluded to, seem to be, Ainsley as well for that matter, seems to be very comfortable with this rather thin notion of autonomy. And I think that that's problematic. So with the routinization of NIPT, as you've mentioned, Catherine, I like that description very much. And how this is being applied to potentially eradicate what might often be perceived as a serious problem like Down syndrome. I think this could therefore create a moral burden on women to terminate pregnancy, for example. And of course, this consumerist approach fails to enable the doctor to appreciate what is valuable or important to the patient. So by autonomy, I understand this to require the doctor to essentially respect what might be consistent with the woman's values and able to live according to or to decide according to her beliefs. So I guess from this relational standpoint, a crucial question would be whether the doctor has given proper acknowledgement to her feelings, her emotions, other subjective experiences, taking into serious account her vulnerabilities, her needs, and her interdependence on others. So while I think we could easily say that the doctor has some moral obligation to recognize the constraints and demands that may be involved in making that choice when a woman finds herself confronted with this particular decision, I guess the crucial question then would be, what more can a doctor do in that sort of situation? Are clinicians sufficiently empowered to do more? I guess that's one of the key question that we would have to think about. So I very much like the insight that Catherine shared in terms of moral disorientation and what Ainsley reconstituted as moral disruption. I think that fits in very well with how we think about these novel technologies as they get mainstream into clinical care. So how then do we expect clinicians to deal with these sort of challenges? And while I'm hugely supportive of what Catherine has mentioned about reproductive deliberation, I do wonder, what about the clinician side of the story? Are they able to help patients realize this sort of rich and thick autonomy that we would want be present in a physician-patient relationship. And I think that this is followed on very nicely with Josie's discussion, and congratulations, of course, on the ethics of sequencing newborns, Josie. I mean, that report is fantastic, and we do use that in our teaching as well. So I think it highlights a number of issues that will be very prominent challenges here in Hong Kong, and I believe elsewhere as well. So in terms of the complexification that we see in mainstreaming whole genome sequencing, of course, perhaps a bit different from Australia, that there's huge interest in this technology, and we are likely to see it having a much greater presence in places like Hong Kong, and also, of course, my home country, Singapore. So you'd see these two places taking on the technology. And then, of course, we are confronted with broader challenges of increasing cost of health and social care. So this, of course, then sets the context where we find these relationships as well as broader systemic constraints. So I think this speaks to quite a number of the challenges that we would find with human genome sequencing technology. And while Josie has noted the cost of such sequencing technology coming down in certain places, I do think that we will also see a problem with the divide that's in the global north and the global south, as this pandemic so vividly illustrates. So I do think that with this technology becoming more prominent, it might spark off a competition of sorts among the already privileged towards normalizing an ideal, or what might be considered to be ideal, but in effect exacerbating inequalities and inequities. So, well, for those who are into literature, I think Kazuo Ishiguro's Clara and the Sun, some of you may have read, it provides a very vivid and I think visionary illustration of this. So to end off, I thought I'd really love to hear from the speakers how they think the ideals of autonomy could be better related to how we think about capability. I think not just in terms of the woman having to make sometimes very complicated reproductive choices, but also clinicians who generally would want to support their patients to make better choices for themselves in order to help them own the decisions that Catherine says. And how does these sort of ideas then ultimately relate to very, very big concerns of justice, I think many of which have been touched upon in the Hastings Center's excellent report. So with this, thank you so much again for this opportunity to share some of my thoughts. So it's over back to Dr. Au. Thanks so much.
Thank you, Kelvin. May I now invite Catherine to respond and comment on some of the thoughts and questions as well.
So thanks both Kelvin and Ainsley. Those are really insightful and instructive thoughts, actually, and I'll just try to respond to it briefly. So I'm going to begin with Kelvin's, actually, because it connects, I think, in an interesting way with that very small, simple question that Ainsley put to me. Kelvin, I think you're right. I mean, the way that we have come to think about reproductive autonomy in bioethics, I think, has really kind of lent hard on a very thin concept of autonomy. So we have increasingly thought about autonomy as a kind of form of really just in terms of negative freedom. And that means what you do in order to kind of allow for autonomy is just get out of the way. Like, it's a freedom of non-interference. So long as people have the space to make choices, that's enough to realise autonomy. I think that's mistaken. I think what that really kind of neglects is kind of what is traditionally understood as the positive dimension of freedom. Now, it may or may not be that we want to use that particular terminology. It has problems. But what we're getting at there is a kind of way in which there are kind of not just practical external barriers to realising freedom, but there might be other psychological or internal barriers to realising freedom as well. And that positive freedom entails this kind of self-formation, if you like, if you don't mind that terminology. So that's where I want to move to, is really thinking about that dimension of autonomy. So with that in mind, though, the question then is, well, what can doctors do to actually promote that? And I think one really important thing to say here is that in many circumstances, doctors are already doing stuff to promote that. The problem with the informer choice model is that it prevents that from being recognised, for one thing. So doctors are afraid sometimes to actually acknowledge the way in which they're really contributing to this decision-making process, because it's seen as kind of not fitting within non-directedness necessarily. There's also just kind of limitations on what they can actually do, but I think actually a lot of times clinicians are quite heavily invested in the decisions that women make, and are actually really kind of engaging in richer ways than we imagine. Not always, but sometimes at least. So I think we should at least be able to recognise when that's happening. That would be a start. But there's also lots of practical things, and this is sometimes just about what clinicians do. I think it's also much broader about what are the kind of what are the conditions for autonomy. So one of the things, for instance, really practical is time. And so by that I mean time for consultations, such that it's not just, here's the information pamphlet and get out the door, I've got to see my next patient. You take these, you make your mind up, and you'll find some more information on the web. So it's that kind of time pressure for one thing, but also time in the sense of time for women to actually make decisions. So for instance, they don't have to make a decision in 5 days because the abortion law restricts them to 12 weeks. So abortion laws that actually allow women time to make decisions after prenatal testing are really crucial, I think, in this space. So time is one thing. I think another small practical thing is just thinking about how decisions are framed. So for instance, we often think about a decision to terminate, whether a woman will terminate or not. So when we frame it in that way, all we're really doing is reducing it to one option. It's about whether you'll terminate or not. But it doesn't take into account that there's this other option, that in fact you will become a parent of a child with a particular form of disability, and that the information around that is lost in that kind of framing. So this is where it kind of relates to Ainsley's question. So Ainsley, it's a super interesting and super complicated question around socialization and autonomy. So this is something that feminist philosophers have been working on for, and we're really concerned about in the kind of early development of kind of relational ideas of autonomy. So I'm not going to be able to say anything particularly novel here, but I think it is a really interesting question when you're talking about not just socialization through kind of the what was talked about as kind of oppressive social relations, but also the ways in which we're actually socialized to hold discriminatory attitudes ourselves, and how we shift that kind of social norm, I think, is really important. But if I can go back to the question about what reproductive deliberation would involve, one of those things is connection. So I think one of the things that can actually help shift that and to actually deal with this question of socialization is actually allowing or enabling women making these decisions to be connected, for instance, with people who are parents of children with those disabilities, which at the moment, they have to kind of seek out for themselves, at least in Australia, that doesn't happen. And while that doesn't solve the kind of epistemic uncertainty, because you still don't know what it will be like for you to become a parent of a child with a particular disability, it can bring at least some information about what it's like to be a parent of a child with a disability, and actually reveal some of the value of that experience in and of itself. It may not be your experience, but it's an experience that has value, that may be worth undertaking. So I think, that in itself can actually kind of help break down this automatic reliance upon preconceived ideas of what it is for someone to have a disability, what it is to be a parent of a child with a disability, and things like that. So I think, that is really kind of reproductive deliberation would really extend our framework out from that kind of brief consultation and then, you know, you go off and make your decision yourself, to actually bringing in a whole bunch more resources to enable women to actually reflect and think critically about their own views on these things.
Right, thank you. And Josephine, your turn.
Hi, thank you. Yeah, thanks for those amazing comments, Ainsley and Calvin, and also to Catherine for a really provocative and right on presentation. So much agreement. So let me just try to answer a couple of questions quickly. I just, in response to something that Calvin was saying about enthusiasm for sequencing in the Hong Kong context, I just wanted to sort of state what I think is probably really obvious, but just to say it out loud, which is that the cost of sequencing is not just the cost of doing the test. So the cost of running the test is going down. The cost of analyzing and interpreting and understanding and explaining and following up on and monitoring and treating the results is huge. And so I really hope that healthcare systems that are looking at the technology will take a really sober account of the full cost of using it inside a healthcare system, especially in non-targeted ways. So even targeted sequencing throws up, sort of unclear and uncertain results, other results that are peripheral to the main result, like all sorts of things have to be sort of sifted through and taken care of. But whole genome sequencing or whole exome is even more so the case that you get a lot. And so the cost of following up on that can be pretty significant. Don't underestimate the cost of ongoing monitoring and ongoing healthcare stimulated by those earlier results. And just to note that we already also know that people aren't super great at remembering the details of a result that they got several years ago, especially if it was about a child, especially maybe right after birth when everybody's a bit sleep deprived. So there are studies showing that people are quite hard at, find it quite hard to distinguish, for instance, the result that they are a carrier or that their child is a carrier for a condition versus that they actually have the condition itself. And that's a pretty important distinction that sort of feels, I think, quite fundamental to people inside genetics, but can get really muddled in the minds of ordinary people, including myself. So that's just an example of the fact that it's very hard to get your results and keep them clear in your mind. And so there'd be help needed to keep revisiting the test results, not even talking about what Ainsley raised about reinterpretation. So just putting sort of fleshing out what the cost really might be. Ainsley asked about family benefit, and we do have a little section. I went back to the actual document to look at that. So in the context of diagnostic, so use of sequencing where it would be more likely to be whole genome, whole exome, so in a NICU or where you have an infant where you're not sure what's wrong, and so you actually have to go on a fairly broad hunt inside the genome to see if you can get any help. We know that when that happens, that it can reveal results that may not actually be relevant to the condition that you're seeing in the child, but could say something else. And an easy example is that would just be a BRCA result, where then you have this question of, well, do you return that as well? So these are sort of classic kind of incidental findings. And in our report, we recognize that the initial diagnostic choices should be driven by the needs of the infant, but that there may in fact also be additional data returned that no one in good conscience can withhold from the family. And so family benefit is something that does make quite a bit of sense. But we were beginning, like many ethicists are, from the perspective of like the care should be driven by the needs of the newborn. And then I just wanted to make a comment about reproductive autonomy. I think we could talk about it all day, but or all night, or whatever point you're at in the cycle of the sun. But I just guess one of the things I would say is experientially about autonomy is that I've found that the more I know about autonomy and think about it, the less, the more I realize how all the things in the way of my autonomy. But that I also think that like understanding that your autonomy is, that it's something, as Catherine said, to be achieved, and that we are all sort of shaped and influenced and constrained by our circumstances and our upbringing and things. If you actually, that process of sort of grappling with the things that are constraining your autonomy is probably an important step in actually being able to realize your autonomy. So that's a kind of like not a very user-friendly way of talking about it to patients probably, but I do think that like helping people to reflect on what might be constraining or shaping their decision-making and as a general matter is a good way to help them become, kind of help them with their decision-making. And I would just say that like one of the things that I just wrote down that book because I have to read it, but one of the things I would like to see in pop culture a bit more and in sort of like movies and TV shows is like a fuller representation of the kinds of decision making that women engage in and families engage in around prenatal care and testing and other kinds of genetic testing, because I think that the representations so far have been a little bit sort of fantasies of like how easy and straightforward and sort of clear. And it would be great to see that sort of thing, because I do think that's one of the only ways to truly communicate complexity is to sort of, and it can be so beautifully rendered in film and television and books. So I look forward to seeing like better, and it's, if any of, you know, there are ways that you can have contact with people who are working in creative industries to sort of help flesh out these portrayals. And I think that's like a good thing for bioethicists to do if you have the chance.
Thank you very much, Josephine. It's now time for the open to the audience for questions and also comments. We are maybe 5 minutes behind schedule. That's largely due to my taking too long introducing to the speakers. They're actually keeping perfect time, each of them. So nonetheless, I'll keep the 20 minutes allocated for the Q&A. But I hope the audience, if they turn on their mic to speak, please keep your question or comments brief as far as possible. Okay.
Someone has their hand up, Derek, I can see. Their little cartoon hand.
Yeah, I think it's Dr. Albert Lee, yeah.
Yes, Professor Lee.
Okay, hi, thank you. I'm Albert Lee. I'm from the School of Public Health and Primary Care of the Chinese University of Hong Kong, and thanks and Catherine JOHNSTON for the wonderful presentation and the enlightening by Kelvin and Nancy. Now, I think I put my head as a clinician as well, family physician. I think we have definitely it's our duty to work with the family, the parents, to make a decision. Sometimes it's a very painful decision. I must say in the old day, it was much easier when I was a young doctor because it's a limited condition that could be diagnosed by genetic testing, and the outcome usually quite straightforward, right, and easy to understand. But nowadays, some of the advancement of technology, certain clinical condition being diagnosed, the outcome might be this way or the other way. The child could grow up normally. So this put us in, as a clinical doctor with the patient, in more difficult position to discuss with the family and parents. And I think still it's our duty. And I think the speaker rightly point out, there's a recognition of the time we need the time and the long-term relationship. And I think that's something that need to be addressed is the, rather than just seeing, you need to see some doctors, it's point quite rightly, the primary care provider, someone who know the patient family, understand the social context well, to discuss the issue. So I think it's really not just, you can refer to expert to do the genetic counseling, but I think it's really someone knowing the patient well should invest the time. And I think there should be some provision for the clinician to address the issue. I don't know whether any, some in terms of healthcare system could address the issue. And also one other quick point is because increasing is a lot of, I just listened to another webinar talking about wrongful birth. And I think it's a public health policy and strategy for screening, but I don't think we have enough public health education along the way to get the public to understand not only the screening, and I think Jocelyn mentioned quite well, is the disability. I mean, both Catherine and also the speaker mentioned, is that understand the disability, the acceptance by the society. And I think that, in a way, the social norm could drive whether parents consider whether to go on the pregnancy with the risk of disability, and still enjoy the parenting and bring up the child. I think, I don't know any enlightenment on, I think we need to do more on the public health education on the aspect as well, and any area we should focus on from now. Thank you very much.
Thank you. Thank you, Professor Lee. Any comments from the speakers?
I would just say that those kinds of relationships are under threat, I guess, and so it's important to realize that how much they might be needed more rather than less.
One of the questions that came to my mind was slightly along the line of what Calvin asked Catherine about the reproductive deliberation. Calvin was asking on the point from the angle of clinicians in practice, and Catherine has really well responded to that. My line of question was slightly different. In what way the reproductive deliberation model, which I really like personally, how would that harmonize, or may that be in conflict with the legal framework of informed consent, for instance, and the usual concept of standard of care when you promote a new paradigm? There may be concern from some clinicians, for instance, whether this may generate high expectations of standard of care and subsequently issues to do with what if I miss out the more ideal form of processes.
I think that's an interesting question, though. I mean, one thing to keep in mind is that we do use a shared care model in other areas of medicine. It is true that there could well be concerns in reproductive medicine in particular. I mean, it's kind of interesting, and I'm not sure, this is not the same in other countries, but as Ainsley noted, in Australia, NIPT has really been kind of brought to market, if you like, in a very kind of ad hoc way, and it's driven primarily through commercial interests. So what's kind of interesting about that from our point of view is that within prenatal testing in Australia before that, so for obstetric ultrasound, for instance, there's no explicit informed consent process. Really, by virtue of turning up at the clinic to get your ultrasound done, you've basically given consent for it. But there is a consent process for genomic testing through NIPT. The problem is that the forms that, when you look at the various forms for consent, they vary considerably in terms of what information they provide, sometimes they don't provide any. So there's a real kind of, there's a combination of a pathology request form and a consent form. So they're not really about the informedness at all. And so it's really kind of falling on how one becomes informed is really kind of left up to oneself, if you like. And I think that doesn't serve doctors well, because then, I mean, one of the kind of complaints that we often hear around prenatal testing is that women just have no idea what to expect when they're turning up to these tests. So for ultrasound, you know, they had no idea that they might get bad results or results that would transform their kind of pregnancy, because they just thought it was a way of getting pictures. So in a way, that seems to me, to come back to your question, Derek, to open up a whole range of worries that clinicians could potentially have in that space as well about standard of care and so on, because their patients are not in a position to be making the decisions that they're going to have to make. So I think you're right. I mean, there's a lot of things that we would need to kind of think about and how to kind of embed a different model here. But at the same time, it's not without precedent insofar as we have shared care somewhere else in other areas of medicine, and that seems to be working okay. It seems to be popular at least. It's true that there may be additional weight to some of the kind of decisions that need to be made in reproductive medicine. But I also think that at the moment, the kind of informed choice model is really not serving anyone well in some ways. It's not serving clinicians particularly well necessarily. It's not serving women and their partners particularly well.
Thank you. And I see that AC type in a side comment also that some of the Australian research forms have now sex chromosome abnormalities as opt-out. AC, you want to slightly?
No, I'm happy to leave the floor to
Yeah.
others. But yeah, Josie, did you want to add to that?
Oh, I just was saying that all of this just makes me realize how I think someone mentioned genomic literacy, and it's not like we all need to understand how the genome, works in complex sort of scientific ways, but just having realistic understandings of like what you can and can't get out. I don't know if ancestry testing has been an especially good introduction to genetics. I mean, maybe it has, because there's been some stories about how people get one result and then, they try a different company, get a different result. So there's some uncertainty and kind of ambiguity built in. But, how some of the early genetic conditions like Huntington's or BRCA, those are really unusual actually. So it turns out that most things are not like that. So just getting people to understand well before they turn up at their appointment, sort of what it might mean to have a genetic test more generally, what kinds of things can come out of that, how confusing can the results. People are quite surprised sometimes when they get a sequencing done and there's no result for whatever condition they were present with, because everyone's just thinking, well, if I have a condition, I'll surely get a result. So there's a lot that people just don't generally know. And so finding ways to sort of kind of get that into the water supply so that it's just not realistic to think all of that education can happen inside of your first prenatal care appointment. Like that's absurd. And similarly, when your baby's brand new, you're not going to learn all of that right away. So just how to get that more into the general understanding of people's understanding of what to expect generally in medicine, so that when they go to the doctor for their appointment, they're not totally blindsided that an ultrasound, just like someone was saying, an ultrasound is not just a way to get a picture of your baby, and a genome and genetic test is not just a way to find out if it's sort of, if there's a Y chromosome or not. So getting a little bit more of that out there and not putting so much pressure on those providers to just squeeze extra stuff into their appointments would be good.
Thank you. That's really well said. We still have a couple of minutes, and if I may ask Josephine to elaborate your point in one of the PowerPoint, which struck me a little. Where you mentioned the slide on the LC, the ethical and social implications, and you said for whom. We talk about LC a lot. In Hong Kong, we are now starting to run the population genome project in Hong Kong after Singapore, UK, and other countries. One of the things that our center has been trying to promote is to get people to talk about the ethical and social implications of the genome project. But now you have a slide that's for whom, and that really struck me a little. So it's not really self-explanatory to say that let's promote ELSI for genome project. There seems to be a more complex issue underlying.
I'm not sure I completely caught all of what you were saying. I'm sorry, about the LC program, or
you had a slide which asked the question when we talk about ethical and social implications. When we talk about that, you said for whom, and then you list a number of stakeholders, which seem to be implying that you can't really talk generically about LC in a society. You have to be more specific. Is that something that you have in mind, or am I leading too much into it?
Well, when I'm thinking about just my own view on that, I guess I am a pretty, I think context is really important. So I'm not a big fan of sort of broad brush principles doing a whole bunch of work by themselves. So I'm always driven to context and trying to understand the particulars of the context and the different people involved and what they're trying to get, what their goals are. And so it's sort of, it can look philosophically unsatisfying, that kind of approach, because it's not like you've got a principle and you're going to just apply it out there in the world no matter what. It's a really context driven approach, but I think it's for a number of reasons more defensible and realistic. And also I just can't get my head out of it. Like, that's just how I see things. So I do think that like all of the LC work that we undertake needs to be really sensitive to context and to all the different factors that and different stakeholders involved in different contexts. That's not to say you can't ever say anything kind of broad brush. I feel like my whole presentation was quite broad brush, honestly. But just that, yeah, so it's a hard answer, really.
Yeah, thank you. Okay, so finally, let me again thank all the speakers and the discussions today. I think Kelvin particularly sort of helped me to sum up the whole range of issues that we talked about today. We went from theme to thick notion of autonomy. We talked about relational and then the systemic or the process factors. And we also enter into some of the more detailed discussions of how things could be in future. And before we close, may I just also announce to the audience that we intend to have another genomic seminar in the later part of this year, perhaps in November. And with permission of the participants today, we're asking them to switch places. So our discussions today will happily present for us on this topic on genomics for health and the issues underlying. And Catherine and Josephine will then be discussing. So thank you all for coming in, and I hope the travel bubble works eventually between Hong Kong and New Zealand and Australia. It seems promising in the coming year, and I hope to see you physically in person in Hong Kong, or maybe I'll come to your place. Okay, thank you so much.